Yeah, thanks everyone for joining us tonight. I think you may well have seen me on other CPD Me seminars. And tonight we're going to be looking at the Mental Health Act. We're going to be looking at Mental Health Act legislation, some of the key sections that you might encounter, but we'll also be comparing and contrasting with the Mental Capacity Act, because I think the two are often perhaps misunderstood or not always appropriately applied. Certainly, in my clinical career, there was a lot of sort of requests for Capacity Act when maybe the Mental Health Act would have been more appropriate, and vice versa. And what I've done, rather than make this be a very dry presentation on Section 2, Section 3, reeling off a load of legislation, I've tried to bring this to life with some case studies to try and highlight some of the nuances there. So for those that haven't met me before, currently I'm a senior lecturer in mental health nursing at university. I'm also a qualified ACP. I do a lot of research, particularly around kind of self-harm, suicide, but also kind of psychosexual stuff. I also occasionally do a little bit of expert witness stuff in civil liability cases, and quite often that involves scrutinising records kind of round wrongful application of the Act, for example. But certainly, I think the reason that I feel qualified to deliver this seminar tonight is that my clinical experience was predominantly in liaison psychiatry, which is mental health provision within the acute or general hospital. So really, especially as an ACP, I was quite often given advice on the application of legislation, sometimes in emergency settings, certainly around kind of treatment of overdoses, when capacity was perhaps variable or questioned. So I do think that I've got quite a good background to be delivering this. I guess, it's lovely that we've got people coming from all over. I suppose this lecture is very much based in English law. I did my nurse training in England. I've only ever worked in England. So I think do kind of just be careful with the lessons you take away from this. I know it's slightly different in Scotland, for example. I've got a friend who's a social worker in Scotland. And she knows that it's kind of different sections and detentions that we use. So do check your local jurisdiction for that. So I think, obviously we can't fully interact, but I just want you to think about this as we go through. There's probably a vast amount of, different professions on this call. You probably come to this wanting different things. But I suppose what I want you to think about is what parts of the Mental Health Act that you regularly encounter. And that's going to be very different if you are in primary care as opposed to secondary care, as opposed to being a paramedic, when it's a lot more ad hoc. And you don't really have the luxury of the Mental Health Act when you're given a first response or an emergency call out. And I think what I also want you to think about is, you've probably heard the term he or she has been sectioned. And what we're going to unpick tonight is what this actually means, because when we look at it from a purely semantic point of view, that phrase is pretty meaningless. A section is just one part of a particular act of law. So yes, I think common usage indicates that we always use that in relation to mental health patients, but we're going to unpack that there's actually lots and lots of different sections of the Mental Health Act. And as I said before, I don't want this to be too dry, and I'm hoping that we get some nice questions, thought-provoking, debate, challenge, because quite often, although the law is very firm, the application of the law is where we come into some ethical grey areas. So we'll start with the basics. The Mental Health Act, 1983, it really covers the compulsory treatment, assessment, and the rights of those people with a mental disorder. And the key part of that is that they are treated against their will. You don't need an act to cover the voluntary treatment of patients. If you think about any patient that you encounter clinically, there is not an act of law that governs that. The Act was updated in 2007 with relatively minor updates, bringing it more compatible with the Mental Capacity Act, which was kind of put in 2005. There was some streamlining of definitions, some enhancements to rights, etc. But by and large, the 1983 Act is still the one that is used. But we do have a draft mental health bill working its way through Parliament. I think the goal of that is really to modernise the Mental Health Act for the 21st century. That's the tagline. That's the spin from the current Conservative government. I'm not going to get any more political than that, but there is also efforts to kind of look at the experiences of autistic people and those with an LD, because people with autism, there's a lot of research that shows that they are constantly sectioned, far more than the typical psychiatric population, and mental health services just aren't equipped to deal with this. It's a very specialist thing that perhaps comes under the umbrella of mental health services, but maybe fits more comfortably with LD services. And the training that we receive as mental health nurses doesn't really equip us to support people with profound learning disabilities. So I think there is a bit of progressive work going on there. In terms of some sections, these are simply parts of the Act that will address a certain aspect. So that's why I said initially that saying someone's been sectioned is pretty meaningless without context, because you can be sectioned on different terms, different conditions, for a set amount of days, a very long time, a very short time. And we'll look at some of these. All legislation has sections. One of the most notorious pieces of legislation in this country has been Section 28. That was the Local Government Act that kind of forbid the promotion of homosexuality, which is very, very controversial, only repealed in the year 2000. Again, you might well have come across other laws that have got a particularly kind of infamous part to it. But absolutely today, what we're going to be looking at are some of the most commonly used sections and the scenarios really that those might be applied. But again, keeping it very, very simple, when do we use the Mental Health Act? So the law is very clear about this. The Mental Health Act is for the treatment of mental disorders. The degree must be of a sufficient degree or nature that warrants inpatient admission. So if we break that down, degree or nature, sort of the type or the severity, is another way of thinking about that. Basically, what it's saying is that the person must be mentally disordered and the presentation's got to be so extreme or severe that they need to be treated in hospital, i.e. they are no longer manageable in the community. And the rationale for that has to be to safeguard their health. So typically with that, we've got people with schizophrenia, psychosis, bipolar, their mental health is part of their overall health. So if those parameters are, really, really distressed, really disturbed, that would be a good application of the Mental Health Act. But the other element here is safety. So typically, we would expect to be working with people under the Act who pose a significant risk to themselves. We see this very commonly applied after a suicide attempt, or perhaps at the disclosure of, real concerns about making a suicide attempt. But also, again, don't want to ham up the myth that psychiatric patients are a risk to others at all times, but sometimes they can be, and sometimes the Act is deployed in order to safeguard, specific people or the general public if that risk is kind of as a direct result of a psychiatric disorder. And I think, the key point here is that there are huge differences between informal and formal, voluntary and involuntary, and these terms are used interchangeably. So if you think about it, almost all patients that we are working with, it's on a voluntary basis. People that come to a GP appointment, who phone an ambulance, who present to hospital, who are willingly admitted. When we think about the law, when that is required, it only really applies to people who are not cooperating, who don't have capacity, or unable to or unwilling to engage. So that's why the Mental Health Act is reserved for most severe cases that can't be managed in the community. And this is always kind of accompanied by this significant concern around risk to self, risk to others, or vulnerability. I think, again, a bit of a myth that, not everyone who's in a psychiatric inpatient facility will be detained or sectioned. A lot of people will be there on a voluntary basis. Although I would argue that I think in recent years, certainly, as you'll all know, regardless of the area that you're working in, the threshold to get into services is so high, and psychiatric beds so rare these days, and so kind of pressured, that you're more likely to need to be detained in order to access one. But again, that's a slightly, that's a resource issue, that's a commissioning issue. So how do we actually get to a Mental Health Act assessment? There's a few routes to get here. But typically, they don't just happen. You don't just magic one up. Normally, someone has to make a bit of a judgment that a Mental Health Act is required. So thinking about my role as a mental health liaison nurse, A&E liaison, general hospital liaison, that is typically when someone presents to the A&E department. Maybe they've tried to kill themselves. Maybe they've got real bad thoughts of killing themselves. Maybe they've been brought in by the police. So in that situation, they're going to be assessed by a mental health nurse. And what will typically happen is one of two outcomes. The mental health nurse will come to the end of what they're able to do. So if we take someone that's quite straightforward, you go and see them, they're a little bit depressed, but they're happy to be referred on for a bit of therapy, GP follow-up, bish, bash, bosh, we're done. There's no need to bring in any restrictive legislation for that. Now, if we take someone who needs the Mental Health Act to be applied, we are usually thinking about someone who lacks capacity. So one thing that a mental health nurse can do is request an admission if that admission is on a voluntary basis. So I had the authority to say, look, this person, quite risky, quite ill, but they're willing to come into hospital. Can we make that happen? And more often than not, that would be fine. Where we would need to follow the Mental Health Act route would be if that person did not have capacity to consent. Now, usually in psychiatry, we're thinking about people that are really psychotic, really manic, and they've got that kind of almost globally impaired capacity to make decisions about their care and safety. So if we felt that capacity was an issue, we'd need to request a Mental Health Act. The main difference, or perhaps the most unique aspect of the Mental Health Act, is that it can be applied to people who probably do have capacity. And again, this is a bit of a grey area, and we'll illustrate that with case studies. But for example, this would be pretty common. Maybe I would go and review someone. They have tried to hang themselves, they've taken a significant overdose. And when I sort of assess them, there are no obviously glaring issues with capacity, but they are hopeless. They still want to kill themselves. If they go home, they will very likely complete suicide. So in that case, yes, they've got capacity, but the nature, thinking about that slide from before, the nature of their illness is so severe that they are a significant risk to themselves. So in that case, you can actually progress and use the Act with people that kind of have got capacity. And that can be tricky for staff and patients, because if you think about it, normally if someone lacks capacity, they're kind of really impaired, altered consciousness, you've got to do stuff to them, but they're not actually objecting to that. It can be a big source of conflict if you are kind of taking away someone's right, someone's liberty, making them go to hospital when all they want to go do is kind of go home and die. So real ethical, moral, kind of real issues there in terms of building up that therapeutic relationship. So we've exhausted all the avenues. We feel that we need a Mental Health Act. What happens next? So if it was me, I would be referring that through to the local authority. Now, they tend to be the ones that kind of take the driver's seat in this. So the key person in any Mental Health Act assessment is the AMP, the Approved Mental Health Professional. Now, until the past 10 years or so, that was 100% always a social worker, but they are opening that up to other professionals. So it's still rare because the pathways aren't as defined, but you can get psychologists, nurses, I think occupational therapists. If you've got a mental health background, you can do that training. And they are the key person, really, because they're the one who's acting on behalf of the state. They will be accompanied by two psychiatrists who are absolutely critical. They've got that medical psychiatrist expertise. They will provide the AMP with a medical opinion. They'll be given independently. One of the doctors typically works for the trust. There'll be the registrar on call, and the other one will be independent. And you usually have a kind of roster of people that the trust works with. You'll get to know your independent doctors pretty well. And bringing this back to the Mental Health Act itself, Section 12 of the Act states that these medical recommendations must be made by psychiatrists who have what's called Section 12 approval. So you've got an assessment of 3 people. By and large, the decision making is pretty shared. The AMP has the final say. They've got to complete. They've got to request the bed. They've got to sign, seal, and deliver it in effect. So the commonly used sections that you might come across, Section 2 is your assessment section. This can last for up to 28 days. Doesn't always. It can kind of be called off at any time. And under this, you can be treated against your will. So typically what would happen is you might need an antipsychotic, something like olanzapine, especially if you're very, very distressed, very agitated, and very psychotic. You do have the right of appeal, and that's all dealt with through the hospital infrastructure. And you've also got the right to a Mental Health Act advocate. And IMHA, you might well have come across IMPCAS, which are independent mental capacity advocates. And typically you'll be discharged by your consultant. Now in law, they will be designated the responsible clinician or the approved clinician. You can also be discharged by the hospital manager. If you appeal this section, it would go to a tribunal. And you can also be discharged by your nearest relative. Now we'll talk about nearest relative shortly because it's a legally defined hierarchy. Everyone on this call can define your next of kin. It can be your mum, your partner, your sister, your friend. There's no real law or, your next of kin is very much self-determined, as in who is important to you. But under the Mental Health Act, the nearest relative is legally defined. And obviously that can bring up some issues of its own. If you are working through the hierarchy and the nearest relative is the mother or the father, but that person is estranged, then you need to work down. It gets a little bit more complex. You can kind of apply to have nearest relatives displaced if they've got issues of their own. But by and large, if things are kind of running smoothly, we'll go through that hierarchy very shortly. Important to remember as well, sections can refer to other acts of law. I've even got into this trap myself. I remember I went to see a gentleman that I'd been working with. He was absolutely fine, no major problems whatsoever. We're working on getting him home. I went to the ward and they were like, "Oh, we've requested a section 2 for this gentleman." I thought, what on earth? He's not even mentally ill. Turns out they had very rightly requested a section 2 from the local authority, and that's basically a request for a care needs assessment. So again, it's always worth checking, because depending on where you work, there may well be other relevant legislation that's kind of involved. So don't do what I did. Don't freak out. Don't tell someone off for doing the job, basically. Section 3, this is typically known as our treatment section. So what will usually happen is if someone gets to the end of a section 2 and they're still really, really unwell, this can be converted to a section 3. This will last for 6 months initially, but it can be renewed for up to 12 months at a time. And I think when I first came into the profession, I thought, wow, that is, it's a long time to have a lot of your rights and your liberty taken away. But I think what it does do is highlight just how difficult to treat some of these, severe and enduring mental illnesses can be. Would definitely come a long way from the old asylum type settings. But every kind of area will have their long stay, very institutionalized patients that are quite difficult to kind of get on top of things, especially if they've got, for example, a treatment-resistant schizophrenia, because that's kind of disability in lots of domains of your life. So again, you do have rights under this. It's not that we just sort of chuck people away and forget about them. We do want to get people off of a section as quickly as possible. If nothing else, they're very, very expensive to the taxpayer, to the state, to the hospital. People on a Section 3 are also entitled to what's called 117 aftercare, and that's where the state has to actually fund a lot of things to support their transition home, and that can be accommodation, carers. So really, thinking about it quite cynically, councils and trusts have a bit of a vested interest in people not ending up on a Section 3. So again, I've kind of covered this. If it's a new presentation or a new patient, someone that we don't know so well, and there are those kind of risks and concerns that we've discussed, a Section 2 is always the most appropriate way to go. It's least restrictive, or should I say less restrictive. Very few situations that you'd go straight for a 3, but it does happen. So I worked with a lady, really complex kind of eating disorder, quite a bad prognosis, physical health parameters would quite often go kind of haywire. But because she had such an established diagnosis of anorexia nervosa, the treatment for that is very defined. So, 10, 20 years into the illness, we don't have to mess around with a Section 2 because we know what the illness is, we know what the diagnosis is, we know what the treatment is. But again, those decisions you need a full MDT approach to that. Community treatment orders, you sometimes hear them called kind of community sections. It's not the most accurate terminology. A CTO, you typically see this, again, treatment resistant, kind of schizophrenia patients, quite chaotic. We don't just go straight in with the CTO. What you need to evidence is that there is a clear kind of concern if relapse does happen. You need to evidence that relapse is pretty common and the consequences of that are pretty severe. Now, typically, when we're working with people who've got schizophrenia or bipolar, they can lose insight. They may be difficult to engage. And so you can get them well in hospital, but actually when they're back in the community, things can kind of fall apart pretty quickly. So what the CTO does, it gives you the power to recall and treat. You have absolutely no power to treat someone in their own home, in their own community. You can't go out and start restraining people, injecting them, giving medication against their will. But what the CTO does is give you a kind of a pretty robust pathway to whip them into hospital, hopefully get them injected with their antipsychotic depot, which is a long-acting medication, and get them back again with minimal fuss. So again, very, very intrusive for people to live with that almost hanging over their heads. So it's used pretty sparingly. But I think the point is, and I teach this to my mental health nurse students, just because someone's on a section doesn't mean we absolutely clamp down on everything. You can still give someone choice and freedom. You can still consent them. I think if I was locked up because I was psychotic, I'd at least want to be consulted on which medication I was gonna take. If you've got to take a medication, at least get the patient's voice on which side effects are more tolerable, or it's not just about let's lock these people up and treat them like animals. It's about let's use this legislation to really look after them, get them well, and get them home back to a normal life. I'll come back to that. Yes, we'll come back to that. It's about a bit of a contrast. I've mentioned this, so the role of the AMP, I don't really need to go into this in a huge amount of detail, but yes, because we are taking someone's liberty away, it's more than simply a health decision. It's really a kind of a state decision as well, which is why the local authority and the government are involved in that. Likewise, the responsible clinician and the approved clinician status, that's actually kind of awarded, I think it's by the Home Office, But yeah, once you've got to consultant psychiatry level, you then have to apply to be an approved responsible clinician. And what that means is that you are kind of legally sanctioned or permitted to look after these very, very vulnerable people. Nearest relative, I mentioned this before, very defined hierarchy. But this is what you would work down. So husband or wife or civil partner. This includes cohabitee, so you don't have to be in a civil partnership, but if you've been living with someone for 6 months, then in the eyes of the law, you would be defined as the nearest relative. Then it goes to son or daughter, father or mother, brother, sister, grandparent, grandchild, uncle or aunt. In the case that there's both, so if you've got a son and a daughter, or a father and a mother, you would go to the one that's oldest. It's just they had to decide somehow, and I suppose doing it in age was what they decided on. There's no real kind of rationale to it other than just needing to have some framework. So to try and bring this to life, I want to work through some case studies with you, and I hope that this illustrates the point. So case study A, we're talking about a voluntary or informal patient. So again, this would be very typical in my clinical job. We've got a 23-year-old female. She presents to A&E following an overdose, and on assessment, she's pretty lucid and she's engaging well. She's upset that she has survived, and she is, she's got no real support network at home. She feels that if she went home, she would attempt to end her own life, but she does agree that hospital would be useful. She thinks that she'd be pretty happy to start medication and contain her risks in the short term. So while she is really quite poorly, really quite suicidal, she still has that kind of hopefulness, and she still has that lucidity capacity to make that decision. So we could admit her on an informal basis. Now, let's contrast this with someone that might need the Mental Health Act. 27-year-old female with a history of schizophrenia brought to ED by ambulance. So this lady's been found near a busy road, semi-naked. She's trying to stop cars. This is from a real patient. I've adapted kind of some of the details very slightly, but this is what happens when people become unwell. So she's been clipped by a car and sustained some minor injuries. At triage, she's refusing observation. She's very agitated, talkative. She's interfering in other patients' care. So again, really trying to highlight the manic, the kind of grandiose nature of this presentation. So she's seen by someone like me. She thinks there's nothing wrong. And she says, right, leave me alone. I've got to go back to work because I'm curing cancer and I'm on the news tonight. You're a waste of my time. Go on, sling your hook. She's clearly not going to engage in a thorough assessment. And I think with all of this, even if you said, right, you're coming into hospital, I don't think she's got the capacity to consent. And even here, she's not wanting that. She's asking to go home. So we've got a few things here. And if we think back to that, the role of the Mental Health Act, it's for people's mental disorder. Clearly, this person is not safe in the community. She's getting clipped by cars. She's getting in other patients' faces. She's just not safe to be in the community. This is because of a psychiatric disorder, and it's of a severe enough nature that she needs an inpatient admission. And it's really to safeguard her. I think what's interesting about this, it just shows as well, you don't need to be suicidal to be sectioned. Yes, this lady's been hurt, she's been clipped. There's no indication here that she's suicidal, but she is at risk of harm because she's so vulnerable. And again, I've kind of alluded to this, but capacity really is that main issue that distinguishes the mental MCA from the MHA. And I think this is what these case studies are illustrating. Now, in the one we've just looked at, fairly clear cut, regardless of how ill this lady is, I think it's pretty obvious she doesn't have capacity. She's not making decisions about her safety, about her care, and this is because of her illness. But I think if we look at case study 3, and I think this highlights some of the nuances, and this is deliberately very, very similar to the first case study. So what we've got this same female, maybe this is down the line. and she presents to A&E following an overdose. But the difference is here, she's not talking to us. She's not disclosing much. Maybe she's given one-word answers. She's upset that she survived. She shows clear signs of depression. She's got no partner, no protective factors. She reckons that if she went home now, she'd attempt to end her own life. And actually, she's ramped it up a notch. She's got a noose, so she's researched on the internet. She's going to hang herself, and she's secured a noose. I've offered hospital because I think she's got capacity, but she said, "What's the point?" So at this point here, let's take all the ambiguity out of it. Let's just say she's got capacity. There's nothing going on really that says she's kind of glaringly out of it, for want of a better term. This is a perfect opportunity to apply the Mental Health Act for someone who is refusing or not consenting to treatment, but is clearly a significant risk. And obviously with the depression kind of assessment, you can make an argument there that suicidality is as a consequence of the depression. So you can pin that to that initial kind of expectation of the act. And I think if I just wing back, clearly put this in the wrong order, but the differences between A and C there just highlight that you can use this on patients who have capacity. In both, they've got a mental disorder, so we've got that kind of we want to protect that person's health. There is a clear risk of harm to self, and that requires inpatient management. There's no way we could really send this lady home and expect her to be well. So while she may have capacity in case study C, there's a real severe depression and there's real imminent risks. Now I'm not going to overcomplicate things. You could argue that if someone's got really, really, really bad depression, that their capacity is probably impaired anyway. But I think, I'm hoping that my point there is illustrated. So in terms of where, a mental health assessment can take anywhere: community, medical ward, psychiatric ward. I'm just going to speed up because I think I've taken a lot of my time. I'm just going to whiz through some acute hospital. So section 5.2 is a doctor's holding power. So medical doctors can do this, very short-term section, 72 hours. So typically we'd see this: someone's come in, they're on a medical ward, they're maybe being treated for an overdose, they try and leave before that's complete, or they've expressed that they're a risk. The medical doctor, to hold them there to wait for a full assessment, can put them on a 5.2. It's a bit less robust. So if we go along and think, actually, maybe the doctor panicked, maybe they didn't really need a full mental health act, we can kind of step that down as an MDT. We can kind of overtake them really, or kind of, have that discussion and have it rescinded. 136, if you're working in A&E, you will definitely have encountered this. So A&E are kind of designated places of safety. So the police can pick someone up to detain them to a place of safety if they are suspected of having a mental disorder, if they're in a public place and they need immediate care and control. It's pretty broad. And I think you'll notice the difference in language. Suspected, with the Mental Health Act, for those other sections, when you come to a Mental Health Act assessment, there needs to be a very clear diagnosis of a mental health disorder. But obviously that's a lot of pressure on police. We can't expect them to diagnose it. So really, when we see this used is if people are a risk to themselves, if they're on train tracks, wanting to jump from buildings, if they are psychotic in a public place. It's a bit of a catch-all to allow police to take someone, and that then has to progress to a Mental Health Act assessment. Some areas have designated 136 suites, so do check that wherever you are locally. Again, this only really applies in England. I don't know about Scotland, Wales, or Ireland, but they are manned by mental health trusts, so it's a lot safer, a lot calmer, a lot more therapeutic. Best practice: always clarify if the police have escorted patients informally. Sometimes we see some quite shoddy, questionable practice. We've had police bring people in handcuffs. Clearly, they are not there of their own volition. But when we ask, what section have you brought them under? Are they kind of under arrest? No, informal. They've clearly not come of their own will. Again, not kind of wanting to criticize. I think resources are a huge thing. If police section someone, there's more expectation that they stay to contain that situation. Whereas if they kind of just drop them off, here we go, he's unwell but informal, they can then scarper. One of the things that you can use to kind of protect yourself and protect the department is ask the police if they will stay under the RAVE framework. I think I'll talk about that in the next slide, but I think as healthcare professionals, we could be better at challenging the police. I think it's human nature, isn't it? If you get told something by a police officer, we kind of see them as law and order. We're not going to question that. But I think sometimes these kind of patrol policemen on the beat, they're not always the most up to date or informed about kind of mental health law and the application of it. So the RAVE framework really covers people. If you've brought someone to the hospital on a 136, if there is any suggestion of resistance, aggression, violence, or escape, trying to abscond, the police really need to stay there to contain that person until the Mental Health Act assessment takes place. And that decision to dismiss police should be joint between the mental health team, the police, and the Acute Trust. You can step someone down. If someone's got brought in on a 136, they're quite calm, quite cooperative, no major management issues. You can step the police down and get security or a one-to-one. Yeah, we're just gonna, I'm not gonna go massively into the Mental Capacity Act. I'm sure there are plenty of other seminars through CPD on this, but I did just want to bring it in to highlight some of the differences. And again, maybe the pitfalls as well. Certainly we got a hell of a lot of referral requests in liaison psychiatry to come and do a capacity assessment, and that's a poor referral because one of the fundamentals that underpins it is that the healthcare professional proposing the intervention is responsible for completing the capacity assessment. So if you're a surgeon wanting to cut off someone's leg, you cannot outsource that decision making to liaison psychiatry. I think, we're a lot more comfortable with the Mental Health Act because what we'll look at is that the MCA is almost exclusively applied to treat physical health issues. Don't get me wrong, we love getting those referrals to consult on or give advice on, but we cannot do the capacity assessment on behalf of someone else. So again, there's a two-stage test. I'm sure you'll all be familiar with this. In the first instance, the person needs to be unable to make a decision, and then you have to kind of reach a conclusion that that inability is due to an impairment, a disturbance of the mind or the brain. And this can be mental illness, dementia, learning disability, but even delirium, infection, short-term intoxication, withdrawal. So this is the diagnostic test. And then when you assess the capacity, you need to consider 4 issues. Can they understand the decision, including, what will happen with or without? Can they retain the information? Can they weigh it up? And can they communicate? So if the answer to those is no, the patient lacks capacity and you progress to best interests. You always want to practice in a way that's the least restrictive and involve the family, the advocate, any advanced directives. The onus is on us to maximize all of this. So if someone's got a language barrier, we don't assume they've got that capacity because they don't understand us. If someone's drunk, intoxicated, we don't make sweeping big changes to their accommodation. We wait for them to sober up. So, we've got a real responsibility as well to maximize decision making. Capacity is always decision specific. People can have capacity to decide what they want for dinner or what medication they want, but they may not have capacity about their care needs or where they need to go to live. You can't dismiss people's, as lacking all capacity due to any one diagnosis. Yes, you could argue that with kind of very advanced dementia, that's so progressive that you eventually will get to a point where you've just not got any capacity to make decisions about your care and safety. But, it's about offering people's choices, using family to work out people's favorite things and just maximizing their kind of quality of life as much as possible. Again, just to illustrate some of the differences here, very quick case study. 78-year-old lady with advanced vascular dementia admitted following a bad fall. She sustains a head injury and she's on warfarin. So really we need to find out if she's bleeding. She doesn't seem to know where she is, and the communication is largely non-verbal as a result of the dementia. She seems frightened and resists intervention. So what we're asking here is, do we use the MCA or the Mental Health Act, or neither? So I think in this one, dementia would usually be covered by the Mental Capacity Act, particularly in this case because it's a physical investigation. We know she's got an impairment of the mind, and it's advanced enough that she lacks capacity. So really she's ticking the boxes on that 2-stage test. She can't understand the need for treatment. She's unaware of the risk to herself, and she certainly can't retain or communicate that. Where we would use Mental Health Act and dementia would be when dementia itself was causing perhaps issues around harm to self, harm to others, or vulnerability. So you do get detained patients on later life psychiatric wards, but usually that's when there's challenging behavior, assaults on family, carers, placement breakdown, significant vulnerability, whether that's financial or, risk to self, gas, that kind of thing, or aggression to others. The Mental Health Act doesn't cover treatment of physical health issues except in very specific circumstances. So coming back to eating disorders again, that's very, very complex. And quite often you need to treat someone physically. So if the physical health concerns are as a direct result of the psychiatric problem, you can use the Mental Health Act there. But typically you might need to use a mixture. So for example, if this lady was on a psychiatric inpatient setting under the Mental Health Act, but she had that fall, hurt her head, you could then treat under the Mental Capacity Act. So you kind of have to weigh it up and look at the purpose.